Hi, everybody. I am coming here today. This is Dr. Mary Claire Haver for those of you who are going to watch non-live on the recorded option. And we're going to be talking about this latest article, myself and Dr. Corinne Menn, one of my favorite members of the Menopausal, which is a contemporary view of menopausal hormone therapy. So let me see if she'll be here in just a second. So this is very, very, very significant. This is a beautiful article just published March 14th or 15th. And this was published in the what we call the Green Journal, which is the Journal of the American College of OBGYN. There she is. Significant articles around menopause hormone therapy that I have ever seen, and that it was published in such a, is holding it up. We're very excited about this.
Yes.
So let's introduce you to my follower since I jumped on first.
Yeah, absolutely. I'm Dr. Corinne Menn. I'm an OBGYN and a menopause specialist, and I'm a medical advisor and prescriber on Alloy platform. And like Dr. Mary Claire, we both love to just get the information to the people. And why we like this article in particular is that it was published in the Green Journal, which is the journal for the general OBGYN, not for the menopause specialist. So I think that's really important, right? And that it really kind of puts into really clear language what we've all been trying to get across the last couple of years, right?
So let's kind of like break down the article in layman's term and why it's so important. So they talk about the kind of history of how menopause hormone therapy has evolved. So kind of walk us through pre-2002 and then post-2002, which was when the bomb went off in menopause hormone therapy.
Yeah, I mean, I think it's just really important for everybody to remember that before the announcement of the WHI findings, which were very problematic in the manner in which they announced it, that it was pretty standard of care that, you know, a woman who presented with clear, you know, hot flashes, night sweats, and disturbing menopause symptoms were prescribed hormone therapy. And it was widely prescribed, and there was a lot of very great, you know, good data, so much so that the WHI was designed not as a study to see if hormone therapy worked. We knew it worked. It was designed as a cardiovascular prevention trial. And that's where everything goes a little bit astray. And so without going into that whole rabbit hole of why it was so problematic, once that message came out and they stopped the study early, and, you know, there was a lot of confusion, it caused women to, you know, stop having access. They came off their hormones, and doctors got really nervous and really confused by the message. And so there really was a before and after of how menopause was practiced, or menopause management was practiced in the world, really, because of this. And so I think one important thing is we all get tired of talking about the WHI, but unfortunately all roads lead back to that when it comes to confusion. And so, you know, the authors who are leaders, I think we should say, in this space, like they're real leaders and highly respected clinicians and scientists. They needed to start with explaining the history of why the WHI was so problematic.
So one of the things is, you know, we had an 80% reduction in the amount of hormone therapy, like prescriptions that were stopped immediately, and then very, very little pickup post, you know, everyone basically stopped prescribing it. They threw their prescriptions in the trash, you know, so only 20% of women continued. And then there was almost no new prescriptions being written for almost 20 years.
Yeah.
So yes, they go into kind of the problematic things about the WHI. Then what really was fascinating to me is they did this beautiful study looking at the different forms of estrogen. And one of the biggest takeaways from this article is formulation matters. So what, you know, talk about other medications that have different formulations and we don't equate them. Like why is this so problematic? You would lump all estrogen together.
Well, again, I think this comes back to like, why is it that everything has to be so controversial in women's health? You know, the authors point out right in the very beginning that there's all different formulations of anti-seizure medications, and there's different formulations of blood pressure medications. And we don't just make sweeping statements on one medication to apply for an entire class. But for some reason, we do that with estrogen. And that's because of the kind of headline grabbing, fear mongering statements that were not nuanced, that the WHI produced. So like you said, we both know, and anybody who's a menopause specialist who understands the data, that there are nuances into timing when we initiate hormone therapy, what type of formulas we use. And the first thing they go into is comparing conjugated equine estrogen, which was the hormone that they used in the WHI, with estradiol, 17 beta estradiol, which is what your ovaries produce and is really the most common form of hormone therapy that I like to say modern menopause management uses, but I do think that we don't want to totally villainize conjugated equine estrogen.
No.
Just to recognize that there are nuances, because I always want to get back to, even if we use conjugated equine estrogen, we have actually really great, positive findings. It's just that for many people, using estradiol might be a better formulation, and it doesn't have the same kind of profile. And I think that gets lost all the time.
Right. We're just lumping all estrogens together, which is why when you open up your vaginal estrogen prescription, they're using data that's 50 years old and has nothing to do with the local small dose vaginal estrogen risks. They're telling you blood clots and, stroke, and that none of that is applicable. And it's absolutely ridiculous that women are suffering because of this, when vaginal estrogen is, and they say this clearly, is safe for anyone, even with an estrogen sensitive cancer. You can use estrogen safely, showing that.
And I think because I think it's really important for people to understand that estrogen has very important basic functions when it comes to inflammation and the small blood vessels in our body. And I think when women can start to understand that, then it's easier to explain things like blood clots and stroke and dementia and cardiovascular protection. When we get to kind of just understand the basics, and and they talk about this, that in the little blood vessels, there's little lining of the blood vessels called the endothelium. It's like little, those little cells. And that the way conjugated equine estrogen and oral estrogens kind of will react there are a bit different than a bioidentical, and FDA approved is what we recommend, bioidentical estrogen. And that the estradiol, what we're referring to, is anti-inflammatory, doesn't increase, C-reactive protein, is actually protective of the lining of the little blood vessels, and keeps the blood vessels very elastic. And they say that, when women go through menopause, their blood vessels get stiffer with the loss of estrogen. But estradiol is very helpful at protecting that. Not that conjugated equine estrogen is terrible, but it has a little bit more chance of having some inflammatory, promoting some inflammation in ways that estradiol doesn't. And so that's just one point. And they go on to look at the different progestins, and whether it's oral or transdermal. So like the bigger idea is formulation matters a great deal.
So when you read through it, how did you feel about your current prescribing practices? And would you mind discussing those?
Yeah, my current prescribing practices is that my preference is for estradiol. So an FDA approved version of estradiol comes in patches, sprays, gels, and yes, oral for people who don't want a transdermal. And then we prefer, and the article goes on to compare the synthetic progestins to a bioidentical FDA approved oral micronized progesterone. And so same with that, we prefer starting with a progesterone. It doesn't mean the synthetics are bad choices, but we shouldn't we shouldn't lump them all together. We need to talk about them differently. So modern menopausal practices are, we prefer estradiol, and we prefer progesterone, and we prefer FDA approved versions of those things. And when we can, we prefer transdermal, but oral is okay as well. And I think it was interesting when they said it's about time. We have to stop using the WHI data as if it's the only data in the world to issue recommendations, guidelines. And the US Preventative Services Task Force still goes back to that data without any nuance, that we've got this large body of other data that shows all of the important differences that you and I are talking about.
Right.
And that's a huge disservice to women.
It is. So it very clearly shows that micronized progesterone, the oral micronized progesterone, you and I both prescribe as the mainstay of what we do. It doesn't work for everyone. Some people have a reaction. I'm so glad we have other options as options, because it's not a one size fits all. Sometimes it's trial and error with dose and formulation, but we both kind of stick with estradiol in some form with the oral micronized progesterone to get our patients started. They go on to talk about breast cancer risk, and you are really someone in this area. Do you mind talking about that?
Sure. And I think so. What's interesting here is, again, and we were just kind of slightly dissing conjugated equine estrogen and the synthetic progestins, but let's go back. Let's bring up the WHI again. And I think what's so beautiful is this picture, which we'll do some reels on in the coming weeks. And this is the data from the Women's Health Initiative that needs to just be driven over and over again to people. So 2 points here. One is that when we look at estradiol and progesterone, we see the least amount of, we don't see any increased risk of breast cancer with either form. When we look at the synthetic forms that were used in the WHI, even those forms are very breast safe. So let me see, Mary Claire on one side. Okay, this side really needs a good explanation. So if you see the difference between placebo and the estrogen and progestin arm of the Women's Health Initiative, that placebo arm is low, abnormally low, because that represents patients who were previously on hormone therapy, and for some reason their risk was unusually low. Isn't that interesting? So anybody who had a previous history of using hormone therapy had an even lower risk of having breast cancer.
Yeah.
So when they compared them to then patients who were starting hormone therapy, it looked like there was an increased difference, but there wasn't. It was no difference. It was just that people who had previously taken hormones had an even lower risk of getting breast cancer. And so that difference was reported as an increased risk, and that wasn't accurate. And so it's on the basis of the misinterpretation of that graph, that data, that led everybody to fear breast cancer from hormone therapy use. And so, this gets confusing for people, but I think it's very, very important that this paper comes on the backs of the "'Tis But a Scratch" article that was published in the Menopause Journal, that was, again, criticizing the way that data was interpreted. But what I like is that this goes even on to make it even more nuanced and say that we know that from a biochemical standpoint, progesterone and synthetic progestins do have a different impact on the breast. So while we, even with the synthetics, don't see an increased risk, we see an even more beneficial profile when we use the FDA approved bioidentical estrogen and progesterone. And let's just say it for the gazillionth time, in the Women's Health Initiative, women who used estrogen alone had a 30% decreased risk of ever getting breast cancer. So, again, we're beating an old horse, but it needs to be said over and over again.
The mantra still is prevalent in many, many doctors' offices. The good this article is article in journal that most OB-GYNs are going to read. Most are not going to read the menopause journals. We will.
Yes.
But this one is kind of your basic go-to journal for OB-GYNs. And it's kind of groundbreaking that this article is here. And we're so excited about it because it's really going to start changing people's mindsets.
Yeah.
So they do a long discussion about cardiovascular disease, like 2.5 pages, basically stating clearly that hormone therapy, if given in the right window of opportunity, is incredibly protective, like 40% decreased risk of cardiovascular disease, which is huge, if you take it within, starting early enough. It's the time away from estrogen where the risk increases. And if we can shorten that time as much as possible, the more protective adding an estrogen after your ovaries fail is going to be, or after, they stop functioning for whatever reason, is going to be.
Very important. And the other thing that I like in this paper is that it's not all about the WHI. So, they bring up and cite, other key large studies that somehow just don't get cited when the U.S. Preventative Services Task Force or the FDA with their labeling. It's like they ignore those very significant studies. And kind of just one of the things that I highlighted here was just talking about bioidentical estradiol and breast cancer risk. The nationwide Finnish cooperative study, a large observational trial, found a statistically significant breast cancer mortality reduction in women using isomolecular, so bioidentical estradiol alone. Or those women using a combination. So that's incredibly reassuring. And it went on to note that when used for more than 10 years, it was safe for the breast. So this study looked at looking at long-term use of it. And it said any history of estradiol menopausal hormone therapy, including when combined with a progestin, so that means any type of progesterone or synthetic progestin, was associated with an up to 50% breast cancer mortality risk reduction. And this remained true for more than 10 years of use and across all age groups. Mm-hmm. Now, it's time. We need to understand it's more than just the WHI.
So what do you feel about, or explain to people what has been driving the healthcare decisions for menopausal people for the last 23 years?
The fear of breast cancer, period. And if after that, it was also the fear of breast cancer, the fear of breast cancer, the fear of breast cancer. And then after that, they think they're going to get a clot or a stroke. And again, that information is actually, misinterpreted and mismessaged to people. People think that hormone therapy is going to cause them to have at a very high risk of having strokes and blood clots. I'm sure you see that all the time where people say, well, what about this?
It's one of the myths that we have, that I'm constantly dispelling. And then people terrified if they have a family history. They don't even have any risk factors themselves, but their mom had it. And they're like, no, I can't. My doctor told me I can't. I mean, unfortunately, most of your healthcare providers and clinicians are not versed in all of this data. And finally, American College of OB/GYN is putting this in front of clinicians, and I fully expect this to be part of the ABOG articles for our CME.
It better be. It needs, so for everyone to understand, for us to be board certified as OB/GYNs, we have to read articles, answer questions every single year. And they have some articles for us to choose from. I personally think they should make this one required for everybody. And there's a lot of devil in the details here, and we're going to work with all of our menopause literate physicians who are out there providing good information, and we're all going to kind of break down this article to continue to give you guys good key pieces. But I think maybe, Mary Claire, I think the one that always is so important is this whole idea of transdermal versus oral. And they explain the ester study. So do you want to talk about it, or I'll talk about it? I think it's super important.
Yeah, go ahead.
Because what happens with the WHI, they using that as a basis for recommendations for practitioners, really muddies the water, because the statements of the WHI that it raises your risk of cardiovascular disease and stroke and blood clots, when we both know that that's not true and that we've got such rich data on it.
Right. And there, again, formulation matters. Again, they're very clear about that, as well as method of delivery. And so a estradiol seems to be less associated with those things, or not associated at all. And the 17 beta hydroxyestradiol, which we would call, I love the way they say
isometric, right?
iso biologic or whatever. I was like, oh, it's so much better way than saying body identical.
Yeah.
That
Oh, isomolecular, yeah.
not have an association actually is protective. And the type, and so, but oral, because of the first pass effective delivery, you can't take Premarin, which is an oral non-estradiol formulation, and and apply it to every other form of estrogen on the market. It just is not it's not good counseling for medication. It is not great prescriptive. But that is the trap we've fallen into. Why? Because we're female. Why? Because it's hormones. Why? Because there is and I'm going to say this and go on the record, there are two schools in menopause. There is suck it up, buttercup. You don't need anything. You'll muscle your way through this. And then there's modern menopause care. And unfortunately, the old school is still trying to write papers, clinging to these older studies, clinging to this older data, who were really powerful in these government institutions. And we are clasping arms across the metaverse and saying, no, we believe the new data. We believe this is a more nuanced conversation. We believe that a woman deserves the option to discuss not only get rid of her hot flashes, which is very important, but the potential benefits and what the loss of estrogen does to her body. That is not healthy.
And this is why, the other important part of this article is the end where it says, what about prevention? And so when you have major government bodies like the FDA, the U.S. Representatives Task Force, making blanket recommendations that hormone therapy should not be discussed at all as prevention for cardiovascular disease.
Ridiculous.
The only reason they say that is because they are relying on only the unnuanced data from the WHI to say that. And they're ignoring large bodies of data that, refute that. And they're basically saying it has to stop because we are losing an opportunity to offer women an option for prevention. They may not choose it, but they should have the option, right? You and I don't think it should be in the water where everyone should be forced to take it for prevention. No, but I think it's really, it's not proper medicine to not allow women to, I feel like at menopause, they should know like, hey, there's something that's FDA approved that's been shown to significantly lower your risk of bone loss, ever having a heart attack, having progression of atherosclerosis, having progression of dementia, and a whole sorts of other things, lower colon cancer risk. And we're supposed to not say that because the U.S. Preventative Task Force said that no, it can't be used for prevention. Really? Are you just ignoring the large bodies of data? Like women aren't, like doctors and women, we need to evolve.
So what, so question coming in, and still, these are things we talk about every day, but we got to keep answering the same questions to understand this information. So, if someone has a hysterectomy, a born without a uterus, an IUD, an ablation, for whatever reason, your uterus does not work anymore. They don't have one. How do we know that they're menopausal or perimenopausal, and what treatments would we recommend?
Well, we would listen to your symptoms. So if you don't have a uterus and there's no sign of whether your periods have stopped or not, you could check a level, right? You could check an estrogen level and FSH. But remember, if you're in that younger age range of, your 40s or your early 50s, that level can really fluctuate. So we can't rely on just one level. Mm-hmm. Really better to just listen to the patient, listen to her constellation of symptoms over a period of weeks or months, and she'll come to you and you'll hear it. And if she still has her uterus present because of an ablation or an IUD, then she has to have some form of progesterone or a progestin to protect the lining. And if she doesn't have a uterus, then you could go ahead and give her estrogen alone. So you don't need a lab test. And please, someone says, I'm thinking of pellets. If you're here on this live, we're going to try to tell you, like, you don't need pellets. We don't want to shame you if you already have pellets. It's probably because you're in a menopause care vacuum and no one's helping you. And so you get driven to the only people who will help you, which is someone from the BioT company who's marketing heavily and profiting on you and giving you pellets. So we're here to tell you, you don't need pellets for any of this, right?
Option. What about biest and triest? Can you comment on that?
So biest and triest, those are compounded versions where it includes estradiol, estriol, sometimes even estrone. I mean, they're compounded combinations that one have never been shown to be any more effective than what we do have, which is FDA approved. If you want them to be bioidentical, there are FDA approved bioidentical options. And so these combination options are no better. They're not studied. And the reality is, in the end, it's estrogen. So whether you're getting estradiol or some biest or triest combination, in the end, it's working on estrogen receptors. So you're better off going with the very, very well-studied, well-documented formulations that are kind of laid out here. We've got data. These biest, triest combinations, we have no data on them. They're unlikely to hurt you, but they're often expensive and unnecessary and being prescribed by people who are probably charging you way too much.
Okay. They do touch on testosterone therapy in this article, and kind of the same line of thinking. I have the discussion with my patients. We know it absolutely, we have beautiful studies showing how wonderful it is for women with hypoactive sexual desire disorder where other conditions have been ruled out. So no more, there's disorders, pain disorders, relationship disorders. A person in a supported relationship or no relationship just misses that desire and it's affecting her and it's making her unhappy. Testosterone can be really a powerful tool. Hard to get the men's version, hard to prescribe the men's version. It's possible. It's easier in certain states than others. It's really difficult in Texas. And so a lot of us will compound testosterone because we don't have a workaround. We don't have an FDA.
And that's okay.
Yeah, and that's why we have compounding. So
there are good compounding pharmacies. We will never here to vilify. Doctors rely on compounding pharmacies, but when we have formulations that are FDA approved and available and well studied, we use those, right? And both of us will prescribe testosterone compounded sometimes. Other times we'll use the male version, but in smaller amounts. Yeah. But women here have to know, because we get asked, how come you don't prescribe testosterone on Alloy or the other telecompanies? They don't prescribe testosterone, and that's because, and this comes down to a regulatory thing that women need to rise up and complain about. So we're calling on all you ladies. Testosterone is considered a controlled substance. It's the only hormone in the world that's treated like a narcotic. So that's why via telehealth, it's very, very difficult to prescribe testosterone. So when you come to these telehealth companies like Alloy asking for testosterone, we're not trying to deny it to you. It's just legally we can't, because they've made it a controlled substance, which is really crazy. Because, like, is Synthroid a controlled substance? No. Is progesterone a controlled substance? No. Why is testosterone? Well, because male bodybuilders abused it decades ago and they've made it a controlled substance, and that's where we are.
Yeah. Okay. If you guys have questions, just drop them in the little box.
And people were asking, I see, about the article. We'll put it in our stories, and over the next week or two, I'm going to be breaking down little segments of this, and I suspect a lot of my colleagues here on Instagram. So yeah, so you'll be getting, so if you want to share it, someone said that they'd like to share it with their OBGYN. Well, their OBGYN should have access to the Green Journal, so they could get a copy of it, but you can even just, you can get the abstract yourself online by just Googling this or going to PubMed and typing in a contemporary view of menopausal hormone therapy. You won't get access to the full article, but you'll at least get the abstract, and your doctor should be able to get a full copy.
All right.
which is great. Because to me, if there was a clinician out there who wanted to understand how to prescribe menopausal hormone therapy, I would tell them download the Menopause Society 2022 position statement, but then take this article, because this article is like the modern nuanced way to take that position statement and put it into real modern action and a modern way to prescribe. I think it's like a beautiful like layer on top of the NAMS guidelines.
Yeah, agree.
Yeah.
Okay, we'll wrap it up.
Yes.
Hopefully you guys learned something. We'll be nuancing and teasing out specific data points from this throughout, on both of our platforms. If you don't follow Dr. Menn, please do. She's Dr. Menn, OBGYN. She's so fantastic. And was kind of lonely in the metaverse before I met up with with the menopause. And now I just feel so much like synergistically stronger, and we do fun things like send articles back and forth on our group chats.
Yes.
So
my phone's always blowing up. My daughter's like, oh, another menopause text thread.
all right, everyone, have a wonderful day.
Bye, guys.